All right. Well, good afternoon. My name is Tom Barrymore, and I'm here to talk to you today about congestive heart failure, right? So we will discuss a few different topics today, and here is a list of objectives that we will look to go over. So real quick, we'll run through these. The objectives for today's lesson are to identify major components of the heart, to go ahead and articulate how blood moves through the heart, how to define congestive heart failure, how to identify signs and symptoms of heart failure, differentiate between congestive heart failure and other conditions, determine the proper treatment for congestive heart failure, and to demonstrate the proper technique for applying CPAP. Okay? So first things first, we'll take a look at the review of the anatomy of the heart, right? Okay, so let's start by just defining what the function of the heart is. The heart is an organ in our body that pumps blood, right? So the function of the heart is to pump oxygenated blood to the vital organs and tissues in your body, right? Because as we know, all our vital organs and tissues require oxygen to survive, okay? So we discussed what the heart does. Now obviously blood is coming in and blood is going out. So let's take a look at this diagram here. You can see this blue tube that comes all the way down. That is your vena cava. Now up top, you have what they label the superior vena cava, and when it comes from the bottom, it is the inferior vena cava, okay? This is part of your venous system, and this is what actually returns blood to the heart, okay? Now, you can see over here, we have this red arc. This is an artery called your aorta, and it comes off of your left ventricle, and it pumps blood with oxygen, so oxygenated blood throughout the body, okay? Now there are also 4 chambers of the heart. The 2 upper chambers are called atriums, and they are left and right respectively. The 2 larger chambers are called the ventricles, okay? You have a left and a right ventricle respectively. And then we'll talk about some valves real quick, okay? So what are valves? Valves are what stops blood from moving backwards in the body. And specifically in this situation, it stops it from moving backwards within the heart itself, okay? So major valves that we're talking about, you'll have in between each atrium and ventricle, you'll have valves. On the right side, you have what's called a tricuspid valve. And on the left side, you have right here a bicuspid valve. All that means is that the amount of leaflets, right? So think of blood as it's coming downward, right? These are the leaflets. In a bicuspid valve, there's 2 leaflets. Blood goes through, and then as blood is going through, it's fine, and then when they close, no longer can blood go backwards, right? So there's 2 leaflets on the left side, and there's 3 leaflets on the right side. There is also a pulmonary valve, which you'll see off of the right atrium going into the pulmonary artery, as well as the pulmonary vein, where it comes into the left atrium with oxygenated blood. There's a pulmonary valve there as well. And then there's also a major valve going from your left ventricle into the aorta. There's what's called an aortic valve. So as you're pumping blood into the aorta to then go to the rest of the body to feed the body with all the blood that it needs, right? There is a major valve that stops it from going backwards into the heart, okay? And that's very important. These valves are used to stop the backflow of blood. Again, very important, right? So pulmonary artery comes off of the right ventricle and goes into the lungs. Interestingly enough, the pulmonary artery, although it is an artery, It is the only artery in the body that carries deoxygenated blood, okay? So it comes off of the right ventricle, goes into the lungs, and then the gas exchange, carbon dioxide to oxygen, occurs in the lungs. And then in the lungs, you'll see, from there it goes to the pulmonary vein, which is the only vein in the body that actually carries oxygenated blood. And it brings the oxygenated blood into the left atrium, which then goes to the left ventricle and pumped through the aorta to the rest of the body, right? So, how does blood flow through the heart? Now, we'll talk about how it goes through the heart, but real quick, let's touch on how the blood actually comes back to the heart, right? So we know that blood goes out of the heart through arteries, which actually actively pump blood to the rest of the body. Now, with the venous system, they actually uses those valves we were talking about. It has a bunch of one-way valves, and as blood goes up through them to return to the heart, they close off, not allowing the blood to back down and go backwards down the venous system, okay? And actually your movement with your muscles, when you walk, when you talk with your hands, when you move around, that muscle contraction actually moves blood through the venous system in an attempt to place it back in your heart, right? So, blood returns to the body through the venous system, and it'll enter with the superior and inferior vena cava. All right? Now, from the superior inferior vena cava, you can see it enters the right atrium, right? And then as it contracts, it goes through the tricuspid valve to the right ventricle. And then as it contracts again, you'll see that it goes through the pulmonary valve and into the pulmonary artery, right? Which we've already established carries deoxygenated blood to the lungs to be oxygenated. So then after going through the pulmonary artery, it gets oxygen, comes back through the pulmonary vein, which also has valves, and it enters in the left atrium, okay? From the left atrium, it goes through the mitral valve with contraction and ends up in the left ventricle, and then it contracts again, going through the aortic valve that we talked about earlier, into the aorta and to the rest of the body. Now, the heart works in a pumping motion, right? If you feel your pulse, you can feel a palpable beat, right? That is the heart pumping, okay? So there's two phases to the heart pumping. The first is diastolic. That's when your heart is filling, okay? So consider your fist, your heart. The heart is filling during diastole, and then during systolic phase, the contraction phase, that's when it's physically pumping the blood out, okay? So preload and afterload, they're very important when we're discussing congestive heart failure because they both affect your heart's ability to pump. So preload is the ventricle filling. When we're talking about the diastolic phase, when the heart is being filled with blood, right? When the heart's being filled with blood during diastole, the max amount of force pushed against the chambers of the heart, or the ventricle, during that filling phase is the preload, right? So basically, the volume in which that is coming in, that's pushing against, that's the preload. The afterload is the pressure that the heart works against while contracting during systole, right? So as you contract, afterload is all that pressure or force that's coming against it, okay? So afterload and preload will be terms we'll use later on to kind of discuss how we treat and what the medications and the things that we're doing affect these and how that assists, right? But when we're talking about heart failure, we're talking about what the heart does effectively, which is pump oxygenated blood. So when we're talking about heart failure is a broad term used to describe a chronic condition where the heart is unable to pump blood effectively to the rest of the body, okay? So, as we talked about before, diastolic filling, systolic is when we're actually contracting, right? So if you're having diastolic heart failure, you can see here the chambers of these ventricles. Because when we're talking about heart failure, we're really just talking mainly about the ventricles failing, because they are the ones that do the majority of the pumping, right? So you can see in diastolic failure, there is a thickening and a stiffening of the chambers of the heart, not allowing the heart to fill effectively, okay? So in a diastolic heart failure, the heart does not fill effectively, meaning that the preload is affected, right? Because if we're not able to get enough in, we have less preload, right? And so then the heart can't pump as much as it normally would because there's not enough returning because it doesn't have space for the preload, right? So then when you're talking about systolic heart failure, it's the inverse of that, where it is actually failure based on the contraction itself, right? So systolic we know to be the contraction phase. So this is actually when they're stretched and thin and weakened the walls of the heart so that it actually can't pump effectively, okay? So when the heart itself is failing to pump effectively, that's systolic heart failure, okay? So let's take a look at how that actually, some of these things can actually cause heart failure, right? So high blood pressure. We know high blood pressure is basically just when our arteries constrict too much, right? But if our arteries are what feed blood, oxygenated blood, to the rest of the heart, and they are very tight and constricted, that would add more pressure for the heart to pump against, right? So it's increased afterload, right? Because afterload is the force in which we push against, causes a weakening and a failure. Same thing with MI. MI affects both preload and afterload, but myocardial infarction, a heart attack, it'll cause tissue death, tissue weakening, tissue damage, which affects the heart's ability to pump effectively, right? Coronary artery disease works very similar to high blood pressure. It increases the afterload. Valve disease, now when we talk about all these valves, if any of these valves are disrupted, then they can allow backflow of blood, right? So any sort of valve disease can cause the blood to backflow, which makes it harder to pump, which could then go ahead and make it difficult and cause a weakening, right? And infection acts similar to MI, right? If we have a bad infection, like pericarditis, it can lead to tissue damage, tissue death, okay, of the heart itself. And if that happens, then you are at risk for some systolic heart failure. So risk factors: smoking, diabetes, high blood pressure, obesity, alcohol and substance use. These are all things that we know affect cardiac and respiratory function. So I won't get into too much detail about all that. But one that is important to note is age, right? So most of these patients will be older because they have to have reached a point where they are having failure to one of these extents, right? And typically your body does not start failing at a young age. Now with that said, one cause that we didn't put in here that could affect a younger patient is there are some people that are born with congenital heart issues, and congenital heart issue can lead to a form of heart failure as well. Okay? Left-sided versus right-sided. So your left ventricle on the left side. When we discussed earlier, we talked about where the blood is coming to enter the left side. So the left ventricle receives its blood from the left atrium, and the left atrium receives its blood from the lungs, right? So if you were to have a left-sided failure, then the fluid would begin to back up into the lungs. Now left-sided failure is the most common between the two, left-sided and right-sided, and it is most often associated with coronary artery disease, which we know to be very prevalent in the United States. So a lot of people are at risk for heart failure. So right-sided, again, we're talking mainly about ventricle failure when we're talking about heart failure. So the right side, we know the right ventricle receives its blood from the right atrium, and the right atrium gets its blood from the heart, okay? Or sorry, from the body. So if the blood is coming to the right side from the body, then the backup of blood would occur in the body itself, okay? Most commonly caused by left-sided. Left-sided is far more common than right-sided, and left-side failure leads to right-side failure, right? Which would make sense because we know that the left side ultimately we back up into the right side, right? Because yes, we are getting it gets its blood from the lungs that just got oxygenated, right? But if you keep following that backwards, you'll see that it goes all the way to the right side of the heart, and that increases the demand on the right side of the heart, which can lead to failure. So the most common side of right-sided or cause of right-sided failure is left-sided failure. Signs and symptoms of CHF. Okay, I think a lot of these signs and symptoms can be associated with a variety of different things, and we're going to kind of talk about why these are signs and symptoms of CHF. So to start with, shortness of breath and rales upon auscultation, right? So shortness of breath, if you're having left-sided heart failure and the blood begins to back up into the lungs, if there is so much fluid buildup in that area, fluid will then enter the lungs itself, and it will disrupt gas exchange. So when you're having a patient that may have heart failure that's having shortness of breath, they're having shortness of breath because there's fluid causing that disruption. They're not getting enough oxygen because of the fluid. And rales is just the term we use to describe fluid when we listen to lung sounds, okay? So rales means fluid in the lungs, right? And so you'll hear, if you're having shortness of breath and there is fluid back up into the lungs, you may hear rales upon auscultation. Swelling and weight gain, the reason those go hand in hand is because if you have right-sided heart failure, we know that it'll back up into the body, right? So you will expect to see some swelling. Most commonly, you'll see swelling like this, where it's in the lower extremities. But you can see swelling in all four extremities and the abdomen as well, okay? And the swelling comes from fluid being backed up into the venous system, right? And we talked earlier about how the venous system uses one-way valves to bring blood back up. Now, if blood builds up, it'll push blood back through the valves. And gravity tends to bring the blood down to our legs, okay? So we will tend to see poolings of blood or swelling, like edema, in the lower extremities, but again, not always. Weight gain is associated with that. If you go to a patient and they have swelling in their lower extremities and you ask them, how long has that been going on for? And they say, oh, a week to 10 days. And you ask them, have you gained any weight? And they respond with, yeah, my legs are swollen and I've gained like 10, 15 pounds in the last week, week and a half. That's a significant weight gain, and it's probably attributed to what we're talking about with the swelling. The fluid actually being built up into that space. Difficulty sleeping. We all have probably heard at some point in our EMS journey that, you know, CHFers don't like to lay flat. That is very true. They can't lay flat. When they lay flat, the fluid then kind of is diffusely spread across the lungs, making it a little more difficult to do the gas exchange. But despite that, they'll also just have difficulty being comfortable. When you're feeling short of breath, when you're having these symptoms, it can be very uncomfortable and disrupt your day-to-day life, including your sleep patterns. You'll also notice a cough with these patients, and the reason they're coughing is because when they have fluid in their lungs, it's an irritant. It's annoying to the body, right? And so your body tries to cough to get rid of it. So they may have a productive cough that has a little bit of pink or bloody sputum, but it may be just a dry cough as well. And a lot of the time, I know we jump to infection when we think cough, but these elderly patients that are potential for CHF exacerbation, the cough should not just be ruled out as an infection-only symptom, okay? Dizziness and fatigue, they kind of go hand in hand. When you're getting that extra swelling, right, and that weight gain, and then you're having some shortness of breath like we talked about earlier, those combined will cause hypoxia, and they may not be very extremely hypoxic. It may have just lowered their oxygen saturation to maybe 90% or so, right? But they can survive at 90%, but they're not going to feel good. Same thing with the weight gain, right? You feel heavier, it's harder to move around. These can attribute to like some dizziness and fatigue. And then any time that we have any sort of cardiac complaint, there's always potential for chest pain, right? So chest pain, if your heart's failing, obviously that's extra strain on the heart, and you can experience some pain from that as well. So the assessment of vital signs. These are not steadfast, right? This is certain things that we could see that would increase our level of suspicion that you may be dealing with some sort of CHF exacerbation, okay? Like we discussed, the backup of fluid into the lung, it causes disruption in the gas exchange, right? So your pulse ox may decrease. When somebody is in severe pulmonary edema from CHF exacerbation, that pulse ox will be real low. They can be really working to breathe. The pulse ox could be in the 70s, 80s. If it's more of a mild CHF exacerbation, they may be sitting around 90, 92%. It's important to do a full assessment to discern why it may have gone down, but you will see a decrease in SpO2 with people that have pulmonary edema secondary to CHF exacerbation. Lower end tidal, okay? Oftentimes we see a lower end tidal with these people. I'm not going to go too much into that on this slide. We'll talk about it a little bit more, but it is typically a normal waveform and a lower number, okay? Elevated heart rate. Anytime we're not getting enough oxygen, our body's defense mechanism is to start pumping more blood, right? Get the oxygen that is in the blood to everywhere as quickly as it can. So you'll see that increased heart rate when you see a decreased SpO2. Elevated blood pressure. This one's big, okay? We see a lot of patients that have elevated blood pressures, and it may be elevated to the extent of like 200 over 110, or it may be slightly elevated above their norm for a prolonged period of time, like 160 over 90, and that prolonged period of increased afterload, right? The pressure in which the heart's pumping against, that may cause heart failure symptoms to occur, right? So elevated blood pressure is very common in a CHF exacerbation patient. And then the increased respiratory rate. When they're having respiratory symptoms, they're going to have an increased respiratory rate. In red, always perform 12-lead EKG. Extremely important. We know that the heart function can be viewed through an EKG, and if we're worried about heart failure, we want to take a look at the heart through an EKG to make sure that we're not missing anything. And the one main reason for this is patients that have CHF are more likely to have myocardial infarction or cardiac event with a negative outcome because they already have poor function of their heart, okay? And we want to rule out that we're not finding any of this, right? So we see 2, 3 ABF, it looks like we've got some inferior elevation. That would be an MI. We don't want to miss any other signs and symptoms. So always perform a 12-lead EKG with these patients. All right, so lung sounds. Number one, we're going to listen to all fields. Do not get isolated on one specific set. So what I mean by that is oftentimes when you're looking for something to confirm your diagnosis of CHF, you may listen to the lower lobes, hear rales, and then get tunnel vision and go, well, I've heard rales, and so it must be CHF, right? Not the case. Lung sounds can be very hard to distinguish. It takes a lot of practice and diligence on a provider's part to get really good at it. And so it's important to assess the entirety of the lungs and not just one specific area, and not to get tunnel vision. If we hear wheezing, we hear rales or rhonchi, don't just immediately assume one thing. We may have a patient that has wheezing that also has rales, or that you notice the rales and then you notice that they've got some wheezing in the upper lobes as well, right? So let's take a quick listen here. And this is some normal lung sounds. So you can note with that, they sound pretty clear. They're kind of soft lung sounds, but they sound clear. The inspiration, expiration, they're about the same length, right? Doesn't sound like there's anything messing it up. wheezing, which is often associated with asthma, COPD, any sort of bronchoconstriction, right? You'll notice when you listen that they're going to have a prolonged expiration because that bronchospasm makes it difficult for the air to actually leave the lungs. So let's go ahead and take a listen to that real quick so we can hear what that sounds like. Yeah, it sounds kind of like your brother crying a little bit, right? Right? But that's the wheezing, that and you hear how the expiration, he goes, prolonged expiration, right? It's because they're having trouble getting the air out. And then rales is the last one. This one is often associated with fluid being in the lungs. This is what we would look for when we're looking for CHF exacerbation. We'd want to hear some bubbling, some crackling, something similar to this, okay? You notice when they breathe in, breathe out, you can hear bubbling, right? That bubbling is what you call rales, okay? So when we're talking about lung sounds and CHF, we're looking for the rales, but these patients may have a wheeze as well, and they may have fairly normal lung sounds. They may also have diminished lung sounds, okay? Which means that they sound fairly normal, but they're very quiet and hard to hear. So it's important to make sure that we listen to all fields, don't get tunnel vision, but also reassess. Even if we haven't done anything for the patient, it's important to continually reassess these lung sounds to make sure that we're not seeing any progression in a negative way, right? We don't want to hear a little bit of fluid, then don't do anything quite right or quite quickly or right away, and then we don't reassess them, and all of a sudden now their SpO2 is dropping, they're really labored in their breathing efforts, and we take a listen, and now that the fluid's everywhere, we can hear it all over, right? So we need to continue to reassess every single time. So we're talking about end-tidal CO2 and CHF, okay? The important thing with this is historically, a lot of textbooks teach the thought of CHF exacerbation, end-tidal is going to be normal waveform, but lower, which is true. If you see this first point, compensatory breathing, meaning they are trying to really work to breathe, they're trying to breathe more so that they can bring more oxygen in because that gas exchange is being disrupted. When you have compensatory breathing, you can cause hyperventilation, which can lead to that patient breathing off the CO2, which would start or give you a lower end-tidal reading, right? But as that CHF exacerbation persists and progress, if the fluid is disrupting the gas exchange so much so that we're not really getting rid of CO2 anymore, then you'll start to retain CO2 and you'll actually see higher readings, end-tidal readings, right? But these are typically going to be in patients that are sick and they've been sick for a little bit, okay? It's not a great sign to see somebody with CHF exacerbation and having an elevated end-tidal without any other underlying conditions such as COPD or asthma. All right, so let's try to put it all together. We got a 62-year-old male patient complaining of chest pain and shortness of breath. The symptoms began as he attempted to go to sleep. The SpO2 is 90%, blood pressure is 180 over 100, heart rate is 106, his respirations are 28, and he has a known history of high blood pressure, diabetes, tobacco use, and COPD. So a few things that stand out right off the bat, okay? Number one, 62. Is that a little bit older? That's old enough to put us in the age bracket where they could be dealing with heart failure? Absolutely. 62, they are old enough, they could be dealing with heart failure, right? The symptoms began as he was attempted to go to sleep, okay? As we noted earlier, it can cause sleep disruptions, it can make it difficult to sleep, so that is kind of pointing us more towards CHF, but it also could be they are having an asthma attack or other respiratory problem that may cause them to be difficult to sleep, right? Same thing with the SpO2, right? We see that the SpO2 is low. but we don't know if that's caused by asthma or COPD or bronchitis or some other respiratory condition, or if it's CHF. We have an elevated blood pressure, which again is often associated with these CHF exacerbations, right? So that blood pressure does point me in the direction of, hey, maybe we're dealing with a CHF exacerbation. Same thing with heart rate and respirations, right? They are both elevated, but they would be elevated in anybody with a respiratory complaint, so it doesn't necessarily rule in CHF. Known history of high blood pressure, diabetes, tobacco use, COPD. He has high blood pressure, which we know increases the afterload. Diabetes can cause vascular damage, which also leads to some heart failure. Tobacco use and COPD are often associated with both heart dysfunction and respiratory issues, right? Since the respiratory system and the cardiac system are so intertwined, that it doesn't necessarily point us in one direction or another, right? So let's go ahead and take a look at what else do we want to know with this patient? What are his lung sounds? What is his end tidal, right? What does his end tidal waveform look like? What does his EKG look like? And is there any swelling noted, right? These are all the things that we talked about earlier that could help us kind of paint a picture. Is this a respiratory condition like COPD, bronchitis, asthma, or is this a pulmonary edema from secondary to CHF exacerbation, right? So if we listen to this patient's lung sounds and we check all these extra boxes here, we'll see that you have rales in the lower lobes, an end tidal of 29, which a normal end tidal is 35 to 45, right? So 29, although not crazy low, a little bit lower than the norm, right? Which would point us in the direction of CHF, along with the rales, points us in the direction of CHF. The fact that we have a normal waveform and we're not seeing any bronchospasm waveform, like a shark fin waveform or pyramid waveform on the end tidal, would point us to believe that we're dealing with fluid rather than a bronchoconstriction, right? We do look at the EKG, there's no ST elevation noted, so we do note that there's no myocardial infarction going on, and there's no swelling. But again, swelling doesn't necessarily mean that there's not a CHF exacerbation. Swelling is often associated with the right side, not the left, right? So this patient didn't have any. If we take a look at this one, I would say based on this information, we lean towards CHF over COPD or another respiratory condition, right? So let's take a look at another one. Putting it all together, we got a 59-year-old female patient complaining of shortness of breath and chest pain. Symptoms began as the patient was walking up the stairs after taking her break at work. Her SpO2 is 88%. Her blood pressure is 168 over 104, heart rate 104, 26. Respiratory, known history of high blood pressure, CAD, COPD, angina, and transient ischemic attack, right? So first things first, age, 59 years old. Is that old enough? Are we looking at potential CHF? Yeah, they're in the age bracket, right? And then the vitals are pretty on par with the last patient, right? They're almost right at the same level as the last patient. And the same thing with the history. The history is not that different, right? So if we're comparing it to the last patient, right off the bat, we're thinking maybe this patient is having some sort of CHF comparatively to the last one, right? We go ahead and we say we want to see these extra things, right? Lung sounds, end tidal, CO2, and the waveform, EKG, and any swelling. We're looking for these extra things to rule in CHF. When we do so, we realize that she's got expiratory wheezes in all fields. Her end tidal is 50, which would indicate that she's retaining CO2, right? Which would be indicative of bronchospasm, bronchoconstriction. Shark fin waveform, also a waveform associated with bronchoconstriction, right? EKG shows sinus tap, but there's no elevation and there's no swelling. So although this patient had a very similar presentation and had a similar history, with these extra questions, we're ruling in that this is probably more of a bronchoconstriction issue rather than an issue of CHF exacerbation, right? And then let's do one more. We got a 52-year-old male complaining of shortness of breath and chest pain. Symptoms awoke the patient from a deep sleep in the middle of the night. The SpO2 is at 88%, 190 over 110, heart rate of 110, respiration is 30. Patient has a known history of asthma, hyperlipidemia, which is just high cholesterol, and high blood pressure. So the age, again, we're in an age demographic where they are susceptible, could have a be having a CHF exacerbation. Symptoms awoke the patient from a deep sleep in the middle of the night. That's never good, right? If you are asleep and you wake up going, oh, my chest really hurts, not a good sign, right? But it also points maybe to CHF, right? SpO2, 88, blood pressure, 190, 110. These are all on par with the other vitals that we saw from the other patients, right? So what else do we want to know with this patient? He does have rales auscultated in the lower lobes and wheezing in the upper lobes. Okay, so he's got both. His end tidal is 38. The waveform looks pretty normal. Okay, so even though we're hearing a slight wheeze in the upper areas, it looks like we're not showing any waveform changes. And the EKG shows ST segment elevation in 2-3 AVF. Right? Not good. Inferior wall MI. Not good. Bad juju. So there's no swelling noted. This patient appears to be having heart failure from an MI, right? And that's why it's important to make sure that we're getting the 12 lead. We don't want to forget about it because we don't want to miss something. So treatment of CHF. So the nitroglycerin, whether it be a tablet or a paste, reduces preload through the venous dilation. So that superior inferior vena cava and the rest of the venous system, if that dilates, right, you make the tank bigger, then you're effectively going to allow less fluid to come back. So we're reducing preload. So the ventricular filling, right, or the diastolic phase, we're reducing preload, which allows your heart to pump out the extra fluid that's in the body, right, or in the heart. Helping with this backup of fluid. So nitroglycerin, and it also lowers your blood pressure through the smooth muscle relaxant, which reduces afterload, right? So if your blood pressure is lower, those vasculature is a little more open, a little less resistance that the heart's pumping against, you're going to reduce afterload. The nitroglycerin will then help reduce afterload and preload. It also gives with opening up that vasculature, it does give somewhere for that fluid to shift to, away from the lungs. So then another treatment that is common pre-hospital is a diuretic such as Lasix, also known as furosemide. This will lower your preload as well as your afterload by just removing your excess fluid from the body itself, right? So we're going to give this to a patient, and we may not see much benefit as a pre-hospital use, but within 45 minutes of giving it, they'll start to get rid of some of that fluid, right? Antihypertensives, common for us is enalapril. It uses lowering blood pressure and reducing afterload. This is an ACE inhibitor. Without going into the ROS system again and re-going into this, it stops the conversion of angiotensin 1 to 2, right? And what that effectively does is lower the blood pressure. It tells your body to lower your blood pressure. All right, so treatment with CHF, very important. Supplemental oxygen is often necessary. Consider nasal cannula and a non-rebreather mask. CPAP in cases of moderate to severe. Be aggressive with our oxygen administration. These patients need oxygen because the gas exchange is not effectively occurring, and so they will need supplemental oxygen. What is CPAP, right? CPAP stands for continuous positive airway pressure. This continuous pressure will open up the thoracic cavity, allowing for fluid to shift. So basically, it's somebody pushing air into your mouth, into your airway, keeping your thoracic cavity open, okay? And so when you're doing that, you're allowing more space for the fluid to shift, okay? It's kind of a common misnomer that the air is actually pushing the fluid into the interstitial and vasculature space, and that's just not really the case. It has more to do with gradient pressures. It's kind of complicated, but just for the sake of understanding what CPAP is doing, just understand that it allows for the fluid to shift. It also decreases venous return by decreasing preload. So when we breathe in and breathe out, it creates a sucking motion of the heart, right? And that increases the pressure in the atriums. That pressure will be reduced with CPAP continually actively pressing it. You no longer get the sucking mechanism that increases the pressure, so you'll have a decrease in pressure, which decreases your preload, okay? It also increases the alveolar surface area. So it's forcing air into your lungs. That opens up the alveoli, allowing more surface area available for gas exchange. So those are the important things with CPAP. So some contraindications or concerns. The contraindications are listed in bold. Altered mental status, patient must be able to protect their own airway. If a patient cannot protect their own airway, they are not going to get that air forcefully put in. We need to make sure that they are alert and conscious enough to protect their own airway. So just because somebody's confused doesn't necessarily make it contraindicated, but if they're altered to the point where they cannot protect their own airway, that's when we get concerned here. Respiratory or cardiac arrest. If they're not breathing on their own, whether it be respiratory or cardiac arrest, right? If they're not breathing on their own, it's pointless to force the air in. We still want their respiratory effort. So if their own respiratory drive is no longer functioning, then we need to move on to ventilation, right? So we won't be giving this to people that are in respiratory or cardiac arrest. Now, and because CPAP can reduce the preload, it can actually cause a drop in blood pressure. So we don't want to give this, it's typically over a prolonged time, but we don't want to give this to a patient that's already hypotensive, because we're going to ultimately reduce that preload and potentially drop that blood pressure more, okay? And some concerns, but not true contraindications, is anytime you're dealing with a hypoxic patient, there's always the risk that they are confused or aggressive or frantic in some way, right? And so anxiety and uncooperation from a patient that's hypoxic is very common, and it's something that's going to only increase as you put something that's on their face that forces air in, okay? And then it can feel very uncomfortable for the patient. So it's very good to explain to them what's going on while you're putting it on, because it's going to feel like somebody is forcing something in their mouth, right, into their lungs. How to apply CPAP, okay? So we remove it from the packaging. I've got one right here. Looks awfully similar to the one that we have right there. You want to size the patient first, right? So you take your mask, you want to make sure you have the right size mask that goes over their nose and underneath their bottom lip at bare minimum, right? This one actually would be a little small for them. So we'd want a bigger mask. Then you want to consider foam versus plastic. The plastic has a little bit of air taken out of it, so it does allow for the plastic to create a seal. I find it to be a lot better to have the foam mask. I feel like you can create a better seal with the foam mask. So then you connect it to your oxygen source and turn it on. Once you confirm that oxygen is coming out of the mask, that it's working, you go ahead and place the mask on the patient and make sure that you're getting a good seal while it's on the patient, right? Once it's on the patient and you're realizing there's no leaks around the seal, the air's not escaping, then you'll have one person hold the mask in place while the other person comes around and places these straps on the patient's head. And you want to place them in a diagonal motion. So if you start with the top right, go to the bottom left, right? And then we want to crisscross so that we're keeping a good tight seal on the mask. Then once you get it attached, you'll go ahead and titrate the O2 to apply 5 to 10 centimeters HTO pressure, depending on your local protocol, right? Oftentimes when we're talking about pulmonary edema, using CPAP for pulmonary edema, you're going to be delivering about 5 to 10 centimeters of water pressure. So if you go based on your local protocols, but that is a pretty steadfast and true statement, 5 to 10. I believe it's actually 5 to 12 is what they say. And these new CPAPs are easy. All you do is you connect it to an oxygen source, and then you increase the oxygen. And as you increase, you'll see this manometer right here, or there's another one right up here you can see, that actually tells you where this ball goes up to. That'll be where the amount of pressure you're at. So if you get up to 10, then you know you've done the right amount, okay? Always reassess. Assess your lung sounds, your SpO2, your end tidal, respiratory effort, and your blood pressure. Make sure you're reassessing constantly. We don't want to get behind the 8 ball on a patient that's having respiratory compromise, right? So make sure we're consistently reassessing the patient. Any questions? You don't have any questions? Okay. Well, thank you for your time today. If there's no more questions, we will move on.